Well, hello, I'm Josh Baker. I am an assistant professor at the University of Pennsylvania, and I work at the Philadelphia VA hospital as well. And I study rheumatoid arthritis and osteoarthritis primarily through VA funding.
Well, welcome to Rheumatology Network, Dr. Baker. I
Hi,
appreciate your time today. Thank you.
thanks for
So
having me.
we are here today to talk about your recent study that was published in ACR Open Rheumatology, a post-traumatic stress disorder, depression, anxiety, and persistence of methotrexate and TNF inhibitors in patients with rheumatoid arthritis. Can you tell me about the study? What were your goals when you started out?
Sure. Well, there's been prior evidence that patients who have anxiety and depression are more likely to discontinue their therapies for the rheumatoid arthritis. And we've also studied this in post-traumatic stress disorder, which is important to those of us that work at the VA. We've also previously seen that people with PTSD tend to have actually higher inflammatory markers and evidence of higher disease activity as well. So we were interested to see whether our patients with PTSD were more likely to discontinue therapies early compared to people without PTSD. And we also wanted to compare them to people who just had other comorbid illnesses like anxiety and depression.
Mm-hmm. And what did you find?
Well, the primary finding was that PTSD looked a lot like people who had anxiety and depression, and that they were more likely to discontinue their therapies early. We also looked at adherence to therapy. So among people who sort of stayed on therapy for some period of time, we found that people with anxiety and depression tended to also have poor adherence to their therapy, so they were less likely to be taking it regularly. And PTSD was less clearly associated with adherence until you looked out for people that had been on it for a while, and you look back at their adherence. After they'd been on it for a while, they tended to also show poor adherence over time. So part of the reason for that was just one of the reasons that we suspect that people with PTSD and anxiety and depression tend to discontinue early is that they're partly not adhering to the therapy as well as people that don't have those conditions.
So you've established that PTSD, anxiety, stress is an issue with adherence. And I wonder why. Why is it so pervasive in rheumatic disease?
Well, this study, we used administrative data from the VA, so we weren't able to get a really granular look at the individual patients that we were studying. So I'm speculating a fair amount here, but I think those of us that take care of people with mental illness, different types of mental illness, it's a lot to take care of a chronic disease, and it takes a lot of close attention and monitoring, and I think that sometimes those other conditions get in the way of that, of course. It also may be that people have a lot of persistent symptoms and they don't feel like they're improving when they're taking their therapies. And that's been shown as well, that people with depression and anxiety and also PTSD tend to have worse symptoms. And so they may not feel the benefit of the therapy in the same way, and therefore may not be as convinced that it's helping them. So I think the point is, I think that it's extremely complex and that we may not be able to answer that question exactly, but there's likely lots of reasons why patients are less likely to adhere and maybe also more likely to discontinue their therapies over time.
Sure. But stress and anxiety can wreak havoc on someone who, with autoimmune condition. It adds to the inflammatory process, does it not? Yeah.
Well, I think that's a little controversial, but there is evidence that people who have stress have higher inflammatory markers sometimes and can have evidence of higher disease activity. Although how much it contributes to like true joint inflammation is a bit difficult to really say for sure. But we do often see that patients who are under a lot of stress feel worse. I think that's absolutely true. And so, whether their autoimmune disease is really worse, I think still needs to be parsed out and really clarified. But certainly people feel worse. And so there's the symptoms are a big part of this. And it's not just that people forget. I think it's also that people feel worse and their disease is different.
Mm-hmm. Now, as a physician who treats patients with rheumatic disease on a scale of 1 to 10, meaning the disease itself, comorbidities like kidney issues, heart issues, where does stress and anxiety rank on a scale of 1 to 10?
In terms of how people experience their disease in
Well,
general?
their outcomes.
Okay.
Yeah.
Yeah, I mean, I guess it depends on what outcomes you are looking for. I think that ultimately, if you're looking at sort of joint related outcomes, how people feel, how they experience their arthritis, those depression, anxiety, stress, those kinds of things are they're majorly implicated in those outcomes. Um, Obviously, kidney disease, diabetes, heart disease, those things can contribute to those, but the effect is pretty variable, I think. So I mean, you can adequately treat somebody with kidney disease in a lot of cases where their arthritis does very well, but I think the impact of stress and anxiety on symptoms is much clearer and much more, I guess I shouldn't say this word, but universal. It's much more predictable, I think. So I think that it's quite important, and as or more important than a lot of those common comorbidities that you mentioned.
Hmm. And how do you address this in your practice and meeting with patients?
Well, that's a really good question. I think that it takes time and getting to know your patient and a lot of talking, and it's trying to assess the disease, the stress, all the different things that are implicated in how people experience their disease, and trying to take each one of them on individually. I think that that's increasingly a challenge in our healthcare environment where we're pressed for time. But I think that it's the most effective way of dealing with those comorbidities is to take them head on and really understand them for that individual person. And unfortunately, they're complicated enough comorbidities that I think that it's not a one size fit all uh, way of dealing with them either. So, but I think that ultimately it takes some time and some consideration and some getting to know your patient.
Hmm. Right. So in treating a patient with rheumatic disease, there are basic parts of treatment, one of which includes exercise. I'm sure eating well and eating healthy, but what about um, therapeutic care in terms of mental health care? Do you recommend this as a regular part of treatment if needed?
Of course, yes. I think that if for
Mhm.
PTSD, I think it's critical that patients get the care they need from a physician that understands the disease. Um, Many of our patients with anxiety and depression do not get treated, do not get the care that they should get. And I think that it's on us to make sure that that happens, and that they first of all, that people understand that there's an impact of those things on their disease, and that getting them cared for can have a real value to them. So, and then also getting sort of referring and getting the help that you need from other docs that take care of this for a living. So, yeah, absolutely. I think that it's hard to say what that exactly is for everybody, what level of treatment everybody needs, but I think it's absolutely appropriate to um, reach out and get people that care if needed.
Mhm. Is there anything else you'd like to leave with our uh, readers today, or those physicians who might be watching this? Any final thoughts?
Well, I think one of the things that maybe we didn't discuss is just people who don't have a diagnosis already. And really, one of, I think, our roles also is to, when people aren't doing well, or they're not, sort of not doing well with therapy, or their disease activity is high, or they're, just not sort of responding the way you might expect, is to sort of screen for some of these things and sort of try and identify them even if they haven't been diagnosed, because they can obviously contribute even if they're not already in their chart. So I think that being sort of aware of the effect that these comorbidities can have, and then looking for them can have an important impact on care.
Yeah. So thank you again for your time today. We look forward to talking with you in the future, following up on some of these studies. So thank you. Yeah.
Thanks so much for having me. It was great.
Thank you.